Hello and welcome. I'm Steve Clemons, editor-at-large of The Hill. Thanks so much for joining us for our program today during Diabetes Awareness Month called Modernizing Diabetes Care, a discussion on modernizing health policy and practice to improve care for persons with type 2 diabetes. I'd like to thank our sponsor, Eli Lilly, for making these discussions possible. Today, care for persons with type 2 diabetes has reached a critical juncture as modern tools and approaches have the capacity to improve millions of lives. But to achieve these results, health policy and practice will need to keep pace with both changing needs and innovations. How should we be modernizing health policy and practice to drive better health outcomes with people with type 2 diabetes? How can health policy expand access to innovations and increase equity, which is a real problem across a lot of healthcare arenas, but particularly in this one? Are we adequately adhering to and leveraging and evolving treatment guidelines and quality metrics? And given the tools that exist, what quality of care should patients expect from their medical providers? We've gathered the experts to answer these questions and more. Before we get underway, a few housekeeping notes. You can tweet us at @TheHillEvents using the hashtag #TheHillDiabetes. We're broadcasting live, and we're going to take your questions throughout the program. And if you experience any trouble with the live stream, don't throw your computer out the window. Just refresh the page. Hopefully that will fix it. My first guest today is a member of Congress and a doctor himself. Congressman Michael Burgess, and he's been a great friend of The Hill, has practiced medicine for 3 decades before coming to Congress. He's a member of the Energy and Commerce Health Subcommittee and the Diabetes Caucus. Congressman Burgess, it's always great to talk to you. Look, I mean, this is a chronic national problem. It's a systemic problem for the health care of the country. And I'm just interested in your many years of service, and you're one of the leaders in the Doctors Caucus in the House. What aren't we doing that we should be doing to change the game on diabetes care?
Look, one of the things that's perplexed me over a good deal of time that I've been here is it's one thing to say we've got to have the proper environment to treat someone, but the cost of medicines, in this case, the cost of insulin, has been a barrier for some people. And it actually attracted a good deal of national attention a year or two ago when prices seemed to be increasing more rapidly than was reasonable. And it's about that time that I came across a paper from pharmaceutical technology that looked into the benefit of providing the rebate for the sale of a vial of insulin to the patient at the point of sale, regardless of coverage, regardless of insurance, regardless of if they're self-pay, if they're Medicare, Medicaid, or commercial insurance. The actual benefit of that rebate goes to the patient at the time of sale. I like conceptually for money to follow the patient in instances like this, and this seemed like something that was a good arrangement. And their study, which they did show a reduction in out-of-pocket costs by several $100s a month. But I think there's also a bigger picture there. If there is increased compliance because someone isn't worried about how they're going to obtain or pay for their medication, you are going to increase compliance. And one of the worst things that can happen to a diabetic is they get out of control. And one of the worst ways to get out of control is to have restricted access to the life-saving nature of insulin. So that was one of the concepts when we debated some bigger bills with drug pricing in 2019, and then again more recently in the Build Back Better Act. I still like the concept of let's involve the patient and make whatever rebate is going to be paid available to the patient at the time of sale.
I mean, that's fascinating. We just had a discussion actually earlier today where one of our participants shared the notion that costs throughout this process end up becoming an inhibitor. And then when you look over, different lines of society, racial, socioeconomic, those really have a disproportionate impact on certain communities to stop them. And he said we really need to kind of get our handle around that. And I guess, given the size of this, with 34 million Americans with diabetes, 88 million potentially pre-diabetic, it's a big footprint issue. And from a science perspective or a health policy perspective, I just wonder, and you know this much better than I do, are we locked into the way we think about diabetes from 10 years ago? Are there things we ought to be thinking about? What are we doing, given all these big revolutions in technology we have, to say 10 years from now, this is the aspiration of where we'd like to be?
It's a very valid question, and one that I ask myself all the time. Are we coming up with a 1970s solution to a 21st century problem? And look, in just the advent of the continuous glucose monitor, what is the biggest complaint that you got from diabetic patients was, I don't like to stick my fingers in order to do a blood sugar check, and I've got to do it 4 times a day. But then the advent of the continuous glucose monitor, so it's not just a 4 times a day check, it's continuous throughout the day. The continuous glucose monitor really does change the equation. And 10 years ago, of course, that wasn't readily available. Now it's becoming more and more available. The FDA, I thought, was a little bit slow as far as approving things referred to as the artificial pancreas,
Right.
where the insulin pump is paired with the information from a continuous glucose monitor to really sort of eliminate some of the difficulties you get into and allow for those minute-by-minute decisions to be studied by algorithm and administered in a more straightforward fashion. I think artificial intelligence, or machine learning, if probably a better term to use, I think that is going to have an impact on how care is delivered in patients who have been diagnosed with diabetes. But look, here's the thing. Well-controlled diabetes costs a lot less. If you're talking about what is the cost to Medicare, Medicaid, or an insurance company, or patients' out-of-pocket costs if they're uninsured, it's much less expensive to manage someone who is well controlled. And one of the arguments that we had back in I guess now it's been 20 years ago, when Part D was being contemplated in Medicare, how are you going to afford medicines for people? And the statement was made, well, Medicare is going to end up paying for an amputation. It would be a lot less expensive to pay for insulin so that the amputation is never necessary. And that's sort of the mindset that you have to have. The cost of doing nothing is substantial.
That's a very stark conceptualization. Thank you for putting it in such blunt terms. But Congressman, when I've talked about healthcare and any of these issues, and we're in like a silo today talking about one aspect of it, but I remind people there are a lot of players in the healthcare system. There are pharmacies, there are pharmaceutical research companies, there are insurers, there are pharmacy benefit managers, there's Medicare, a lot of different players, and so in that, there is, there is incentives challenges on occasion to how to get the equation right for the patient, and not every patient is the same. You have not supported the Affordable Care Act. I'm just wondering, when you kind of look at that health ecosystem, and if we're to basically look at ways to get health care better and right, I mean, maybe that's too big a question, but what are the dimensions of it that you think can be shifted so that we're, beginning to knock diabetes down a bit as a challenge, beginning to get this? I know that the cost of drugs is one aspect of it, but are there other parts of the health ecosystem that you think need to be addressed?
Sure. I am generally not a fan of consolidation in healthcare. I think it has not worked to the patient's benefit. But you look at the situation we have today, where a single company may own the insurance company, the provider network, the PBM, and the dispensing pharmacy. If that is true, if all of those are aligned under one roof, it seems like diabetes would be a situation where it's tailor-made. Let's do the right thing for the patient that happens to be happily the least expensive option, which is to provide the medicines in a timely fashion so the patient doesn't have to worry about or try to restrict their access to medication. They can remain in tight control, and if necessary, provide them the ancillary tools. You would never try to manage diabetes without some type of glucose monitor, and the continuous glucose monitor, I believe, is going to replace the intermittent monitoring for the most part. Why would a large insurance company / provider network / PBM / dispensing pharmacy, why would they not want to put all of the tools necessary for the correct and accurate management of that patient, which again turns out to be the least expensive type of care to deliver. Someone gets out of control and ends up in an emergency room in diabetic ketoacidosis. That is a phenomenally expensive healthcare interlude. Far cheaper, far more straightforward to take care of things as and keep the patient well controlled and educate the patient as far as what are acceptable parameters for their continuous glucose monitor. But it's let's utilize, all hands on deck. Let's utilize all the tools at our disposal. Now, Medicare is perhaps an opportunity where this also could come into play. Medicaid has a few more variables, but in the managed care Medicaid model, there are also some opportunities there. So these are things that I think where you integrate the entire system. And again, no fan of consolidation, and I'm not making an argument for consolidation, but if you have consolidation, why not make it work out well for the patient?
Thank you for that. One of the other areas I've been interested in is sort of advanced research and where the dollars are going. And if you kind of look over time, this arena of diabetes has had a sort of smaller share, in my view, data-wise proportion, if you look per capita over time. And again, coming back to the question of looking at what we do in advance, my understanding is that part of the new legislation that has just been passed, signed, and I may have some of this wrong, is that a new ARPA-H platform will be built that's sort of like an ARPA, the Advanced Research Projects Agency of the Department of Defense. Now we're going to have an Advanced Research Projects Agency of the National Institutes of Health to begin looking at certain of these areas. I know there's a lot of enthusiasm in the diabetes community for advanced research there. Are you hopeful? Is there a bipartisan support around the notion that more research dollars being poured into this may give us, the next to the CGMs, the glucose monitors, but the next advances in treating this?
Well, obviously that would be the goal. I don't think ARPA-H has quite made it across the finish line yet, but there are a number of people who are talking about it. There, of course, there will be the standard appropriations for the National Institute of Health that will come through before the end of this year, where certainly some attention should be given to this field. ARPA-H may be part of the next iteration of the Cures bill that, remember, Cures for the 21st Century, that was passed back in 2016. There is a new version of that is now being shopped, and the ARPA-H concept is an integral part of that. There are other members I know on the committee who have introduced their own standalone products for an ARPA-H type product. But I think you see, and this is bipartisan, I think you see pretty widespread support for, and it's not so much taking it out of the realm of the National Institute of Health, but how can you deconflict some of this stuff and get big things done with less burden and the deliverable to the patient in a more straightforward fashion.
Well, thank you. Congressman, we are taking questions from the audience, and we have a good question for you from Kevin Donnelly. Kevin?
I'm Kevin Donnelly, president of DHI Advisors and strategic advisor to Fruit Street Health. Intervention at the prediabetes stage would greatly reduce morbidity and mortality. Programs such as the CDC's Diabetes Prevention Program have shown excellent results, yet CMS doesn't reimburse virtual DPP. Why not fund the programs that work in modalities that reach citizens in their homes?
Thank you, Kevin. I think this comes along the lines of what you're talking about. Prevention makes a lot of sense. But, Congressman, your thoughts?
You're asking me to justify why CMS is not doing something that they should be doing? Don't put me in that position. But he's right. If the CDC has promulgated guidelines, the barrier to implementing those may be the lack of reimbursement for and CMS has at its disposal the ability to do that, at least within the population that they control, that is patients on Medicare and Medicaid. There is within the Department of Health and Human Services, created in the bill that was the Affordable Care Act, another part of the agency called the Center for Medicare and Medicaid Innovation. And it seems to me that this would be an ideal activity for CMMI to undertake. CMMI is supposed to demonstrate savings in order to justify its demonstration projects, but this seems one where the savings would, in my opinion, would be pretty straightforward and pretty easy to identify. I will say one of the problems that we have across the board with doing things at the federal level is the Congressional Budget Office has been in all the headlines the past couple of days for some other reasons. But the Congressional Budget Office will look at things in 10-year increments. And one of the difficulties with that is anything in the preventive health space shows up only as a cost because the benefit is going to be several years out. This is one of those instances where I think the benefit is measurable, and yes, while it may be in the second decade that the CBO would have to score, the CBO should be able to take a look sort of into the future as to what the savings would be for the active management of the pre-diabetic.
You know, I just want to tell our audience that I interviewed Representative Raul Ruiz recently, who's a Democrat in the House, and he basically exploded on TV over exactly the same point, that there's a lot of frustration about the disconnection between making both financially but also health-saving investments, but not having the benefits scored and the savings scored. And so there may be an opportunity across the line to work on some of those issues.
I have been doing that for the past many years. It's difficult because you're involving several committees of jurisdiction. It's not just Energy and Commerce. Dr. Ruiz and I both serve on the Energy and Commerce Committee. I'm also on the Budget Committee, and they'd have a part of that as well as both the Senate counterparts to those committees. So that's the difficulty, is sometimes the committees of jurisdiction can work at cross purposes. The ideal world is we would work on what's best for the patient.
Representative, just real quick, last thing, I want to give our audience an understanding. You know, you're out there in Texas and you're talking to your constituents. You're a member of the Diabetes Caucus. I don't know how to put it, but how big a deal is this to your constituents? How much do you feel hope and frustration and connection with your constituents on the subject of diabetes care?
Well, certainly there was a lot of anticipation for the so-called artificial pancreas, the ability to get glucose information without sticking one's fingers. I know I heard from groups of diabetic patients for several years that was one of their chief dislikes about how things were managed with their condition. So, you know, the cost of care, cost of medicines, and this is not just true in diabetes, the cost and complexity of care across the board is one of the things that I think we as policymakers, we need to pay attention to that. It's all well and good to say we're enacting a new policy or a new program, but every time there is something that is pushed out that's a little bit different, we add to the complexity that the patient then has to navigate. And it's not always easy to navigate all of the different parameters that we'll put out there and the sort of between the patient and their doctor and their medicine and their better health.
Which do you prefer better, Dr. Burgess or Congressman Burgess?
Dr. Burgess polls a lot better than Congressman. So mother always called me doctor, and that's what I prefer.
Well, Dr. Michael Burgess, who happens to serve in the House of Representatives from Texas, member of the Diabetes Caucus, thank you so much for joining us today.
Great, thank you.